Congratulations for this excellent presentation. We are moving to the next speaker. Next speaker is Dr. Carlos Rodriguez from Mexico with his presentation, Surgical Indication and Management of Facial Nerve Injuries. Dr. Rodriguez, floor is yours.
Thank you, Lucas, for the introduction. And I want to thank to Salman for the invitation to this wonderful online meeting. Can you see my screen now?
Yes.
Okay, well, so now I'm going to talk about facial nerve injuries. I don't have any disclosure, and all of you know what are the functions of the facial nerve, not only expression, communication, speech, but also a lot of important functions. So as you can imagine, after a facial nerve injury, this could lead to devastating consequences for the patient and with a severe impairment, and this influences the quality of patient's life. This is the second cause of facial palsy after Bell's palsy, and comprises around 6 to 27% of all facial nerve palsies, including iatrogenic injuries. So iatrogenic injuries, specifically cerebellopontine angle surgery, comprises around 75% of cases, followed by temporal bone fractures, especially those transverse fractures that violate the otic capsule in 7 to 10% of cases. And there are less frequent cases of trauma. So treatment is determined by several factors, and it's very important to consider the site of injury. I mean, if it is intracranial, intratemporal, or extracranial location. So for clinical evaluation, there are some scales that we can use, but maybe the most important and the most common is the House-Bragman scale. Okay, so this scale divides the facial palsy in 6 degrees. 1 is normal, 6 is a total paralysis, and here you can see some patients with different etiologies, okay, with different rates of injury. Electrodiagnosis is also an important investigation, especially to consider surgical management as well as imaging studies, especially for the evaluation after trauma, when we need to consider what are the features of the fracture, by example, and as well as the evaluation of preoperative evaluation of facial nerve in the context of cerebellopontine angles. So briefly, according to the etiology, we can divide the location in intracranial, intratemporal, extratemporal, and as you can observe in this table, okay, intraoperative injuries are very common due to blunt trauma and compression, okay, so this may lead to traction of the nerve or compression of the nerve. Lacerations are less common, but it is possible to have an injury like this. And what about the goals? Okay, we need to procure eye protection, oral competence, nasal obstruction, as well as muscular tone to achieve a good symmetry and a smile for the patient. But remember that there is no technique that restores for completely the facial function. And what about the available techniques to restore the facial function? We can divide these techniques into groups. One group for the restitution of function, and the second group for the substitution of function. The first group comprises dynamic procedures, okay, used to improve movement. And the second group, the so-called static procedures, used to promote symmetry during rest. And what about dynamic procedures, okay? So there are many procedures, but the rest of the talk is focused on the use of nerve transfers, okay? Remember that a nerve transfers consist in the use of a nerve or part of this nerve to be rerouted and connected to the distal end of an injured nerve closer to the end organ. So what about facial fascial direct neurography? As I said before, this is not a common type of injury, but it can exist, okay? And this is used when it is possible to reanastomose without tension. But in some cases, it is not possible to reanastomose without tension. So in these cases, we need to use a graft, okay? And here you can observe the results. And nerve transfers, okay? Basically, the use of two nerves, hypoglossal nerve and mesenteric nerve. And with the hypoglossal nerve, we can consider basically three techniques. The use of a classic technique, this means the use of the whole hypoglossal nerve, then the hemihypoglossal nerve, this means the use only of a part of the hypoglossal nerve, and it's possible to use an interposed graft, but this is not broadly recommended. And finally, the use of mesenteric nerve, mainly to reinnervate the lower third of the face. This is an example, a short example of the hypoglossal facial nerve anastomosis. We need to dissect the hypoglossal nerve, and then this nerve is rerouted proximally to be connected with the stump of the facial nerve, the main trunk, using always microsurgical technique. So I'm going to skip this video just to show the final anastomosis. And this is the result in a patient after almost 2 years of injury. So as you can observe, well, this is a not bad result. What about the use of hemihypoglossal facial nerve anastomosis? In this technique, we need to reroute the proximal facial nerve after a mastoidectomy, and then this end is rerouted distally closer to the hypoglossal nerve. So with this, we can achieve a terminal-terminal anastomosis using only one part of the facial nerve. As you can observe here in this short video, with microsurgical technique, we can dissect only a part of the hypoglossal nerve, and then is connected in an end-to-end fashion to the main trunk of the facial nerve, using only a few stitches, no more than 2 stitches. And at the end, I like to reinforce the suture line with fibrin glue. And then this is the result. You can observe in a young patient an improvement in movement and also in symmetry. And what about mesenteric facial nerve anastomosis? Okay, I'm not familiarized with this technique, but this case was provided by one friend, Wilson Faglioni from Brazil, to reinnervate the lower third of the face, also with good results. Static procedures, okay? There is a huge list of techniques and strategies that we can use, okay? As I said before, to improve symmetry during rest. And as you can imagine, very important technical considerations. So to conclude, these 2 nerves allows a perfect size match, a direct coaptation, that this is very important for a nerve reconstruction. And what about the outcomes? Using these 2 nerves, we can achieve a good improvement, okay? The big difference is in the tongue sequelae, okay? Maybe the patient might complain of speech, swallowing, and chewing alterations, but with tolerable deficit. None of these techniques can achieve spontaneity of facial function, and this is very important, okay? Time is muscle. So we need to have a deep knowledge of the anatomy. We need to procure a careful clinical evaluation supporting on electrodiagnosis. We need to operate as soon as possible if no improvement is seen, okay? And we have many surgical options, and we need to adapt the surgery